Well, welcome to ISELP In-Motion, and we are here today at AEP with Dr. Katie Seabaugh, and she is fresh from the Kester News Hour that she did this morning, and we're going to talk about a variety of subjects, but one that Katie and I have talked about, and I've had the opportunity to hear her speak several times, is orthobiologics. And so that's something that's near and dear to my heart, and I thought I would talk to someone a lot smarter than me about it, even though I may still have opinions occasionally. But so Katie, welcome to ISELP In-Motion, our podcast.
Thank you very much. I'm very happy to be here, and I don't do these very often, so excited to see how this goes.
Have you ever done a podcast
I have,
before?
a couple, but not very often.
Okay, well, we're going to have more fun than they did at this one.
Amazing.
Okay, that's our goal.
Okay. I want to have more viewers than my husband usually has, so if we could work on that, that would be amazing.
I'm glad you picked a low bar, but we'll go from there.
Okay.
So, Katie, I've known you for a lot of years, and but some of our listeners haven't. So tell me a little bit about the path you took to get where you are. And I, of course, know you're a boarded surgeon and boarded sports medicine, but kind of how'd you get here?
Oh, thanks. I appreciate that. I grew up in Montana. And actually, I grew up in Kalispell, which there's a huge event that's there. And so there was actually quite a few horses in that area. And I got exposed to horses at a fairly young age. My family raised cattle, though, and I wanted to go to vet school actually to work on cows, which my parents were not thrilled about. But and when I got to school, I realized that I could specialize. You know, I hadn't really been aware that specialization was something you could do. I think I've taken a little too far. I mean, every step of my career, I have specialized more and more. So I grew up in Montana, went to vet school at Washington State, I did undergrad and Washington State. So then went to California for an internship and had the opportunity to, I guess, get a taste of all around veterinary medicine.
Now, was that UC Davis or private?
It was private. It was at Pioneer.
Okay.
I had a great time there, and Dr. Luke Bass and I were intern mates, and so the fact that we still work together is it's a daily humor, I would say. So that has been great. And fortunately, I matched with CSU for surgery program, so I went there, and I loved surgery. I went into it thinking, I could fix all the fractures. And then you realize that post-op management of horses is hard. The surgeries are the fun thing. The post-op management is hard. And so what did I do? I chose to go to sports medicine, where it is persistent post-op management, basically. Now I predominantly do sports med and rehab, but I have a huge research side, and so keep my surgery skills in hand for that side of things, and try to answer some of these questions that come up all the time.
Yeah, we're gonna talk about this because I know you've been involved in some really interesting research, and some of it's very directed to orthobiologics. So I want to definitely get your brain thinking about that a little bit. And you, of course, still ride.
I do, yeah. I took a break from it for a while, couldn't afford it, basically. But I got back into eventing I would say 2013, and it's been kind of a slow start, but in the last few years it's been really good. So now I have to decide if I'm going to look for another horse. That's the scary thing for me. I love the horse I have. I know him really well, and the idea of a new horse is...
Well, I can tell you what my wife would say about that is you need a pair and a spare.
I love that. I just need her hand-me-downs. That's what I need. I need her to just get them and then send them to me when she doesn't want them anymore.
No, I don't think you want those, because those are the ones I can't fix.
Oh, that's true. That is true.
And now, you also, in your spare time, became a FEI, official veterinarian.
Yes. I, of course, the reason I do what I do is I love the horse, right? And watching the elite eventing horses near and dear to me. And when I was a kid, as many kids do, I thought, well, maybe I'll go to the Olympics someday. And then very quickly realized I was not cut out for riding in the Olympics, but this side of it has given me the chance to potentially work on Olympic level horses or go to the Olympics with a horse as a veterinarian. I don't think I'll go that far, but it gets me closer than my inability to sit the trot would have gotten me. So.
Well, I'm sad we won't see you riding in the Olympics, but I know you can do plenty of other things. And one of these days, we've got to get you more involved. I know it's harder to do FEI out here in the West because most of the competitions are just jumper shows. And you, of course, would like to do eventing.
Yeah.
And more of that opportunity is back in the East. But we've got to get you involved in that. We'll work on that.
Well, one of the things, too, I don't know if you know this, but my husband travels a fair bit. And so for me to travel to some of these events makes it, a little bit challenging.
Well,
do you know anyone that controls his travel schedule by chance?
No, I don't.
No? Okay.
But one of the things that if our listeners don't know, and I think not many people in the veterinary world don't know, that Katie is also married to Dr. Kurt Selberg. And Kurt Selberg is, of course, very involved in ISELP and has been and one of our primary speakers now. So I apologize for taking him away from you and the family as much as we do. But I know he's always anxious to get back home.
And we've gone to some very cool places along with these travels, so it's very good.
And I as a mentor to Kurt over the years, as a mentor, you cannot really comment too much on their personal lives. But there were a few times he was dating this one girl, and I go, oh, that's never going to work out. But I just kept that to myself. And but when you came along, I knew it was going to be, he had just the right amount of keeping Kurt in line and still having fun.
Yep, absolutely.
So I know you and your family have a tremendous time, and we love seeing, my wife and I love seeing you. So we'll try and see you at the AECs next year.
I love this. This is great.
Okay, so we're gonna get back and talk a little bit more on orthobiologics, and there's obviously been a lot. It used to be, of course, when I was early in my career, you had 2 flavors of steroid.
Yeah,
and that was it.
Yeah.
And then this thing came along, and I got involved in doing some of the trials on this hyaluronic acid. Now, that was a new deal. So then we come along, and then we start seeing these things like IRAP comes along. And then after that comes Prostride, and then after that and PRP's been there, but it wasn't very popular in veterinary medicine for years. And I remember when I was sitting at a talk one time, and we're up there on a panel, and I'm talking about putting PRP in joints, and everybody else was university but me, and they looked like I was growing a horn out of my head because that was just not done. And it is interesting to me that a lot of the students from the last 5 or 10 years, it's a real mixed bag as to whether they know anything about orthobiologics. And it's what the school chose to teach them. And I think you guys at CSU are ahead of the curve. Because you do a lot of research in it. Now, so if I'm gonna say, okay, Katie, my wife's out there eventing and her horse is a little sore, and I'm pretty positive it's in the front coffin joints. So what orthobiologic or product are you gonna reach for?
Oh man, isn't that the $1 million question?
Yeah, it's hard because it used to be there weren't
Yes.
many choices. Now there's a ton.
Absolutely. And I just to speak to the student side of things, I think that is one of the big things that we run into in the education is we now have so many things. If you just look at joint therapies of what we have to try and teach the students, it's hard because some of them aren't interested. They may not be tracking equine or be passionate about it. And then we have to decide, is this core? Is this really and with so many orthobiologics, so many joint therapies, it's hard to get that in amongst the entire rest of their curriculum. Because if you figure the amount of information that is just in joint therapies has increased, well, so has diagnostic tools and even diseases themselves, right? There's something new that gets diagnosed all the time. And so it is hard to try and decide when or how much to emphasize some of these therapies. And a lot of it comes down to whoever's teaching it on that particular day and what they're most comfortable with. So it is challenging. And I'm not surprised that students don't know it as much because there's so much that they have to come out learning.
Yeah.
CSU's overhauling their curriculum, which I'm pretty excited about because I think it's due for CSU, and every school does it at some point, and for us it's going to be in a couple of years we'll do a major overhaul and introduce a new curriculum. So hopefully then we will reduce some redundancies and be able to send them out with more information. In regards to what I would choose, it really is the $1 million question. I mean, that is the question every resident for every case will ask. How do you choose which one? And to be honest, I choose a different one on different days. It just depends. It depends. I mean, finances is a huge one for us. Sure. Convenience of preparing it is a major player. I came through when IRAP was big, and I still love IRAP. I love the volume that I have. I love the results that I see. But if I don't have it on hand to treat that day and I can't make it back to see that horse for a while, then it's not going to be something I can reach for.
Now, before we go off IRAP, the original recommendation was to treat again. Mm-hmm. Do it once, then do it twice, and then sometimes do it third time. Mm-hmm. And the rationale, as I understood it, was that the interleukin receptor, antagonistic protein, there was only so much of it in that injection, and then you were going to run out of it in that joint, and you were going to have to replenish it. Mm-hmm. Okay? So, and that's one of the reasons I kind of went off IRAP after a few years. Mm-hmm. Is I didn't want them coming back in. Mm-hmm. So
kind of treat them and street them, huh?
Treat them and treat. Well, I have them back in 30 days. No, but you bring up a really valid point, because one of the things I've always said over the years is if you're going to do joint therapy, doesn't matter what you're putting in them, mm-hmm. okay? If you are not rechecking that horse at 30 days to say, hey, this worked or it mm-hmm. didn't work, then you need to go back and look at your paradigm and say, okay, well, was it a diagnostic failure? Did I diagnose the wrong thing? Or was it a treatment failure? So that was my little bit of negative on IRAP, but I know a ton of people love it, still use it, keep it frozen, mm-hmm. a lot of, and so, but do you still go back and follow that kind of protocol or not?
Honestly, not as much. That was absolutely how I did it all the time, and I don't think there's anything wrong with that protocol. There is a paper that's out there that I cannot remember the author, but they did a study and they looked at how long it was in the joint, and really they actually felt that you needed to treat them every 2 to 3 days, because that IL-1RA leaves pretty quickly. It's either used or it leaves, and so there is a component of what you say is true, like that we should probably follow up with it for multiple treatments, and so that is kind of carried on But why do we do it for shockwave too? You know, we do the same protocol often for shockwave as well. And so I tend to reach for it in the series of 3. Sometimes it's because I need that horse to rest as well,
Yeah.
you know? So you can definitely be, if I'm treating a meniscus or I'm treating a tendon sheath where there's something that's more than just inflammation, then that protocol works great because that horse gets that extra time off, and I think it can be beneficial. I have started reaching for it as one-off treatments, and I've been pretty happy with it. And you know, honestly, that's how I treat my horse. I don't do a series of 3. I just treat him once with what the IRAP I have stockpiled, and I carry on. I think the important thing that you touched on as well is, are we treating the right region? And that's where steroids got us a long way. Because let's take the coffin joint. You mentioned the coffin joint. We can put steroids in the coffin joint, and we know it's basically going to treat that entire foot. So whether that horse has coffin joint OA or pedal bone inflammation or navicular, the steroids are going to get that, and you're going to take care of it. I don't think the same goes for any of our orthobiologics. Those molecules I don't think are going to diffuse outside of the joint as well. And so the number one thing with orthobiologics, if I could say to anyone, is you can't treat them like you treat with steroids. You need to know that is where the problem is, and then you're going to see the results. And I think you will see superior results as long as you are treating the right area. Whereas steroids, even a systemic effect, you could be treating coffin joints and the horse has, you know, neck pain. We often saw improvement in those horses because of the systemic effects, and we're not going to see that with our orthobiologics.
Yeah, I think that's a great point, is that I'd had the exact same impression, is that the orthobiologics, you're putting in a joint or a bursa or a tendon sheath, and that's where they're staying. They're not going to diffuse out like the corticosteroids of my youth were, and cover a variety of sins.
Yeah.
And even if I missed something, it's okay. I got it anyway.
Absolutely.
And when you do that, you have to be a little bit more accurate on that diagnosis, and maybe that means advanced imaging that you wouldn't have done otherwise.
Absolutely.
And think of those things when you're using the orthobiologics that you can get away with on corticosteroid. That's an excellent point, and I think one that doesn't get brought up enough.
But we have our imaging modalities. I mean, this is the cornerstone of what you're teaching, right, is imaging. And with our access to CT and MRI, way more than even when I graduated from vet school, you know, we have the ability to make better diagnoses. So we should be able to treat better too.
Well, and it's one of those things that, you know, the people, of course, there's the cost aspect of it. And, you know, the saying you've heard me say a little bit over the years is, absent a diagnosis, you know, surgery is trauma, medicine is poison, alternative therapy is witchcraft, and rehab is a waste of time. And if you don't get that diagnosis correct, and we've all had the experience. I had a horse come back to me and spent 2 months at a rehab place and wasn't getting any better. They finally brought it back into me. I had nothing to do with this horse's diagnosis. I'm giving a second opinion. I look at this horse, the diagnosis is incorrect. And the rehab they've been doing was completely inappropriate. It was probably hurting the horse rather than helping it. And, you know, what do you say to those people? They've probably got $10,000 in that horse in diagnosis and rehab, and the diagnosis was wrong. And that could have been, the practitioner could have double-checked themselves on, okay, yes, I can't decide whether it's proximal suspensory or whether it's hock problems. I've localized it to this area. I think it's there. And they've got x-rays and an ultrasound they weren't too confident about. A fan beam CT would have told you everything you needed to know in 5 minutes. And so when people ask me about, well, those diagnostics are pretty expensive, well, gosh, it would have saved about $8,000. Why didn't we do that?
Yeah. But I mean, you and I both know we've all made misdiagnoses, right? I mean, yeah, I couldn't even begin to count the number of times where maybe I went one way and was wrong. And so it is tough. And I think everyone has to realize that happens. But the more thorough you are, reach for those diagnostics when you can. They are more accessible. I thought it was interesting today, although I was preparing for Kester, but in the keynote today, Dr. Temple Brennan made a comment about too many tests, and I cringed a little bit. And again, I could be completely taking this out of context because I was preparing for Kester, but I thought, oh boy, I don't think we do enough tests in horses sometimes to try and get the right diagnosis.
And the thing I think about, I go and I'm working this horse up and I decide this is proximal suspensory in the hind limbs. Okay, that's a big diagnosis. That horse is gonna have to have time off. And then I worry about, there looks like there's some arthritis in that hock too. And so I'm trying to come up with a rehab plan and a treatment plan that's gonna. And if you sit there and think about it, my treatment plan, and I have always gone with they need some time. So my shockwave therapy, say for that, is going to be 3 times, 3 weeks apart, and then I do a complete reevaluation 30 days from the last shockwave. Because I want to give that horse some time to heal that soft tissue as well as therapy. But if I've got this wrong, then I'm 75 days down the road before I figure this out. And if I'm wrong, I cost those people this much money and I cost them that much time. And so now that was earlier in my career, I was willing to kind of flip that coin and go with it. And now I'm just not very willing to do that because I've seen it when you delay that for so long that horse is out, because then you got to come back and you redo the diagnosis. Then they've still got time down the road. And so, and what I've learned in working with Olympic horses and lots of good horses over the years is that time they have in the English sport horse from 5 years of age to 15 years of age is precious. And
I feel right now. I feel like, I'm in this window.
You're in that window. It's kind of like the NFL with a rookie quarterback. You gotta work in that window. And you really do have to pay attention to it. If you shut that horse down for a year, that's 1/10 of its athletic career. You just got rid of or wasted away.
Well, and then you think about bringing them back, right? I mean, it takes twice as long to bring a horse back as the time that they've had off if you do it correctly. So if you've rested them for that period of time and then all of a sudden want to bring them back, there's another year that potentially you're bringing them back. So I totally understand.
Well, another question I had on Orthobiologics is we talk about PRP, and PRP, we can talk about first generation Orthobiologics and second generation and third generation. Well, PRP was the granddaddy of them all. It was there long before. If there's maybe 100 papers, I'm maybe being generous, in veterinary medicine on PRP. There's 10,000 in human medicine. And you go to some of these human things and they're off talking very esoteric stuff about PRP, where I feel like sometimes we're still walking. We haven't started running yet. But this question keeps reoccurring, and the longer I've done this, the more this question reoccurs, and that is there a significant difference between leukocyte rich and RBC rich PRP, and then the desired one, which is leukocyte poor, RBC poor, PRP, because I hear different opinions depending on who you ask, and the literature doesn't, it tries to answer that question. And then, my little anecdotal version, which is we use both in our practice. Can I tell the difference? Not very easily. But I'd love your opinion on that.
Well, I do have just that, though. It's a lot of opinions, right? But there's a lot I can say. So first of all, I'm going to ask you, do you know what, you say you use multiple kits, but which one do you use the most?
Well, we use Magellan,
Okay.
which is leukocyte rich, RBC rich, and our practitioners tend to do that. Sometimes they use it in clinic, and almost all the time they use it out clinic.
Okay.
And then in the clinic, we have the luxury of a little laminar flow lab.
Okay. I got you.
And
You make
so
your own.
we can double spin and make our own, and we can make 40 or 50 cc's, which if I'm doing a back articular processes and I'm doing an SI and they want the coffins done, well, I'm even 40 or 50 cc's, I'm pushing the limit on it. But the kits make a lot smaller amounts. And then you've really got to start, I feel like, compromising some of your therapy because, hey, if you want more volume, you can use some more of that platelet poor plasma over here. Well, yeah, but I just diluted all my platelets.
Fair enough. And one of the other things, too, is how often do you do quality control do you measure how much you have in each one of your samples?
We don't, each one, excellent question. and I had gotten a new CBC chemistry machine in, and I thought I was going to do it, and unfortunately I find out it can't do it. But no, I'd love to do that. What I do is occasionally, about once a month or so, we'll go ahead and on whichever modality we're using, either the laminar flow hood or the Magellan, and we'll draw blood off the horse and we'll take a sample off that and we'll send it into the lab and we'll get platelets both pre and post.
Okay. The reason I ask that is a lot of us don't know, right? You can say I have a leukocyte rich product or I have a leukocyte poor product, but unless you measure it every time, there's so much variability that you may not know. Now, the leukocyte and red blood cell to platelet is pretty predictable for the most part, but the degree of concentration of your platelets is highly variable. So I did a study recently. It was a pilot. I don't have anything to report on the study itself, but I had used a new kit. And part of that study was to measure like pre and post. And that kit, I had less platelets and less of all my cells in my PRP product than I did in my whole blood. And so we spent weeks troubleshooting where this is coming from because it had been reported that we should have 10x concentration. And ultimately, it came down to our centrifuge. Our centrifuge was not working, and it was the centrifuge that the company had recommended, but we had an older version, and at some point in that centrifuge's career, something shifted. And I mean, the idea that my centrifuge was going to alter, I mean, how many of us put it in, spin it, draw it off, and inject? We don't even think about it again, right? So the point to that is we can talk all we want to talk about of what is right, what is not right. Do we want high concentration, low concentration? Do we want red blood cells? Do we not? But unless we're testing every sample, we just have to trust that what we're putting in is going to do what we hope it to do. And there was a surgeon I worked with this last year. He's a human surgeon. And I asked him the question, the exact question that you've asked me. Should I be using high concentration? Should I be using platelet rich, platelet poor? And he looked at me and he said, honestly, it doesn't matter as long as you use it. Great point, right? it really may not matter. And we can deep dive into what our cytokine concentrations are. And I love that. That is my passion. And I had a friend give me a hard time about it recently of like, oh, great, where somebody else is measuring what cytokine concentrations are. And I will probably for the rest of my career try to answer which one is best. But the bottom line is I don't think it matters. I think as long as you're using them and you are following your cases and you're making the diagnosis, you will find that they will be successful. I have not had one yet where I've said, oh, this didn't work. But as long as the rest of the package goes with it. And so I think we will continue to try and answer. We will continue to ask, are fat-derived stem cells better than bone marrow-derived? Research will tell us no. But we all know we're still using them, or we'll move on to the next thing, cord-derived or allogeneic versus autogenous. And to be perfectly honest, every horse is different. Every horse is going to give a different cytokine profile based on whatever cells they are or what their mood was that day. So it doesn't really matter as long as you're using them.
Okay. Well, that's really good answer. I like that.
And I think, people will get nervous about, well, should I use this product or that IRAP product or the other IRAP product? And always go to the literature if it exists for it, but each horse is going to be different. So. Yeah.
And now, let's talk about A2M for a minute here. And A2M, alpha-2 macroglobulin, has been around just a few years, honestly. It hadn't been around for a long, long time, like, say, PRP. And, of course, all of these other orthobiologics, besides the one that's just spun down trying to mostly get alpha-2 macroglobulin, has alpha-2 macroglobulin in it. And, of course, bodies, ours included, don't have much alpha-2 macroglobulin in joints, but have plenty of it circulating in our blood and our liver and all that. And I always thought it was funny. I got my knees injected before my knee replacements, and with alpha-2 macroglobulin, and it definitely helped. But in talking to the surgeon who was doing it, I said, well, what do I need to stay away from? And he said, alpha agonist type things, but that's not a big worry. I'm not going to inject myself with Rompum. And
hopefully.
So I'm doing that. And I said, well, what can I do to improve my A2M concentration? And he said, well, that's easy. Either you go out and do very strenuous exercise, like go run a 5K, okay? And I said, well, my knees may not be up to that. You got anything else? And he says, okay, well, yeah, there is another thing. You can just kind of go on a bender the night before. And he says that stresses your liver like crazy, and it'll jump up the alpha-2 macroglobulin. And I go, yeah, I don't think my wife's going to like that either. So I just went with the alpha-2 macroglobulin I had.
Yeah.
But there's been a lot of discussion about alpha-2 macroglobulin and what it does, and of course it's an anti-protease. So I know you've been playing with it off and on over the years. What's your take on alpha-2 macroglobulin and where we are with it?
Well, I'll be honest, I don't use it.
Okay.
Unless it's included in one of the other products I reach for. And there's no real great reason for that, except for that at the time that it was maybe becoming more popular, I felt overwhelmed with what options I already had, and the idea of getting yet another system to try and
another centrifuge.
Yeah, exactly. Exactly. I just think I wasn't quite there for it.
Okay.
And I think the anti-inflammatory component of it has some value, but you and I spoke about this a little bit before, was at the time it was just alpha-2 that was included in it, and so the concern was, well, why wouldn't I reach for something else that had not only anti-inflammatory, but maybe some of my pro-regenerative cytokines and proteins as well. And so ultimately that is what I reached for. Since then, there have been some studies that have come out to kind of say, well, what else could be in alpha-2, and I think it includes other cytokines. I think we don't know. We what do I want to say? We budget to screen the ones we know about. But every day there's a new cytokine that somebody says, oh, this one's important. And then we scramble to say, well, can we test for it? And do we know what it means? And so I think that, do we really understand what is in each of these products? If we're looking at cytokines and proteins, no. We know what the big ones are, alpha-2, IL-1RA, TGF-beta. Some of those we know and feel confident testing, but trying to figure out what is in all of them, it's hard.
Yeah.
One, it's expensive. I've tried, one of my first grants that I wrote when I came back to CSU was I was searching for the cytokine soup. Like, I wanted to be able to say...
No, I remember talking to you about that.
What soup is in each of these products? And it is a passion of mine. I've kind of touched on that. But the cost to run all the tests and then the variability that goes with each horse, and it's still something I strive for, but ultimately I have kind of fallen back on, maybe it doesn't matter because we will never get the full picture for what's in all of them. But again, I think we have good products that are out there, and the more we use them, the more comfortable we'll become.
Well, and I agree with you. I think more work needs to be done in some of these newer products. I've had the impression that the anti-inflammatory effect of it is pretty profound, particularly on some soft tissues. But again, more work. So as long as I'm asking on others, what about amnion products? Any opinions on those? Those are, it goes anywhere from practitioners saying, I use those, I blew a joint up, I'm never going to use them again, to other people who say, I don't even use steroids anymore, I just use all amnion.
Well, and I'm going to pause for just a moment. I still use a lot of steroids. I mean, this talk sounds like I'm like...
Yeah, I know. But it is on Orthobiologics, to be fair.
So I just wanted that out there, that I by no means have completely given up steroids. It is definitely still, it's easy, it's cost effective.
And effective.
Yes, and effective, yep. So I just want that out there for the group to know that I am by no means have given up steroids. It is, I would still say, the large percentage of what I use. But going forward, the amnion, I don't know. I didn't adopt some of that. I used them a little bit, and then there was a little bit of like that poor marketing or backlash of whether they were what they said they were. And then as of late, I've been involved with more of umbilical cord rather than amnion-based. And again, I honestly don't think that you could say that one is absolutely better than the other. I do think that our allogeneic products, the freeze-dried ones, really, in theory, should be more consistent than some of our other products. And we may find that as we move forward, that those are going to be the ones that we end up falling back to because it's more consistent. The potential that we are... Dr. Dave Frisbee and Aaron Catino are working on a freeze-dried eye wrap option.
Oh, really?
Things like that. If we could find something like that that's consistent, I think our confidence in the products will go through the roof. So as long as that's the appeal of those, is they should, in theory, be much more consistent than our autogenous products. But
yeah, well, that's going to be, of course, the next generation, which are going to be, shelf-stable products that you can carry in the truck, you can pull off a shelf, you can squirt a little bit of water in, and then you can put it in the joint. And that's whether they're going to be PRP, whether they're going to be A2M, whether it's going to be amnion products, whether it's going to be exosomes. probably the next big thing
Yeah.
that we know very little about
Absolutely.
so far.
Yeah.
Now, here's one that's a little off this topic,
Okay.
but still has a profound effect within the joint, and that is polyacrylamide gel.
Mm-hmm.
And of course, I know you've done some of the research involved in this, so can
Absolutely.
you give us your take?
I was wondering if we were going to go here because when you think of the term orthobiologics, the polyacrylamides being synthetic doesn't really...
Right, it's not derived from the horse.
Yeah, absolutely. But often, one of my early interactions with one of these products was at a regenerative medicine conference. And I thought, well, why the heck is this product here at this regenerative medicine conference? But I do think that there is a strength in these products in that if we're looking to move away from corticosteroids as much as we can, I think these polyacrylamides are a viable option. They have... I think their messaging early on has confused a lot of practitioners. We've heard, are they neurotoxic? And I think that made a lot of people nervous. I do not think that they're neurotoxic, but that should speak to their effectiveness because a lot of people thought the only way that they can work this way is because they're neurotoxic, because there were some profound responses in some horses. And I think the bottom line for me is no, there's been enough research to say that they're not neurotoxic. The other marketing that I think is challenging is we do have two different types of products. Right, we have a 2.5%, which we're probably not supposed to say brand names, but that's going to be our Arthur-Med. And then we have our 4...
You can say whatever you want. It's my podcast.
Okay, great. The 4% is Noltrex. And I think an important thing to remember with that is those are going to be different. I think they are going to have positive effects, but they might be different positive effects. And so I can't speak to the 4% because I haven't used it in a number of years and I haven't done the research on it. And so I'd have to defer to somebody else about their level of research. But we did just complete a study with Arthur-Med. That company invested a lot in to put them into the carpal chip model, which is our osteoarthritis model at CSU. And they invested in looking at kind of everything. I mean, we looked at RNA sequencing, we looked at joint capsule elasticity, we looked at cytokines, we looked at clinical signs. There was really nothing, there was not anything we didn't look at, I think. And that has been a big project. We are still in our final stages of finalizing our final report and getting it to publication, but it should be there in 2026. And I will say, as I watched these horses go, I did all the lameness exams for this study. And as I watched them go through on lameness, I hate to say it, but I was unimpressed. But one of the downsides to our model is it is a mild, maybe to moderate lameness induction. And so the fact they all kind of looked the same. And that's sometimes can be the fault of the model. We can't induce significant lameness for this model without having some issues with animal welfare. But that aside, so I finished the study and I was unimpressed. But as we roll through some of their data that's come through, there are some significant changes that have happened. And the one that I found most interesting was joint capsule elasticity. So we know that this product goes and it incorporates into the joint capsule. We can see it readily on histo for all of the synovial membrane, and so it incorporates in that joint capsule. And we sent off samples. So we had joint capsule of sham, so the non-OA joints. And this is, we just harvested straight from the front of the middle carpal joint and sent them off. And we had sham, so the non-OA. We had the OA that had received saline injections, and we had the OA that we had treated with Arthur-Med.
Okay.
And what we found was our saline-treated OA joints had a significant change in joint capsule elasticity, where it actually became more elastic, more abnormal, whereas those that were treated with the Arthramid basically matched the sham controls. And for me, that resonated, because what I have seen in horses that have instability in joints. Let's take your bad collateral, or those horses or a carpal joint that maybe has an intercarpal ligament damage. Those are my most profound lameness or lame horses.
And difficult to bring back.
So difficult to bring back. And so for me, it resonated that, let's say, we didn't know this, but let's say when you induce OA, you get instability within your joint, right? And maybe that joint capsule is what is helping to stabilize that. And if these products stabilize that joint capsule and keeps the limb more, in a very minor manner, keeps them more stable, then I can totally understand why some of those profoundly OA cases got better. Does that make sense?
Yeah.
So it was not something I was expecting to find. There are other modulations. The RNA sequencing was quite exciting, where we found that they were, it had stimulated kind of innate immunity and helped control inflammation. So there was actually some changes associated with that. And then we also found, unexpected for this product, but cartilage changes. So the intermediate layer of cartilage was much better. So I had better cartilage scores than our control horses. And so for me, the picture is, if I know, but here again, you can't just treat this in horses and not know if they have a problem there. But if I have an OA joint and I've confirmed that there's either synovitis or OA, low-grade OA, then I think rather than that OA progressing because there's minute instability that's happening from there on out, which we know makes a picture for OA, right? If we can stabilize that, I think that's why you're getting the improvement you're getting.
And does that go to the point of what's always struck me with polyacrylamide gel treated joints is that when you get them sound from that, and it doesn't happen overnight, it's not like a steroid injection.
Yeah, absolutely.
All those changes are happening, is that then it lasts a lot longer than any other therapeutic I have. I mean, I'll never forget a case I had that was one of our hunt horses. And that horse we treated with corticosteroid and HA, did not get better, had a carpal metacarpal lesion, and then treated it with one of the PRP-like products, didn't get any better. Treated it with polyacrylamide gel, and that horse was sound for 3 years, and then it came back, retreated it, sound for another 2 years. And the x-ray was not pretty, but the horse was sound.
Yeah. And I guess I am going to put a plug in for rehab, and now I'm kind of looking at this in a similar light as I look at some of my rehab. We all have had cases where the horse is maybe coming back from injury, they look terrible, or they have imported in and they haven't been doing much, they've lost fitness, they look terrible, or young horses that have no fitness, and they'll say, oh, something's not right, and you can't even begin to know where to begin on some of those horses. And then you put them into a program, and suddenly the horse looks a lot better. And I feel fitness and strength helps tremendously for those horses. And for humans, that's classic for back pain, right? You can't just treat backs without adding in strength exercises to then prolong that reaction. So what if our polyacrylamides are like that, right? What if we are strengthening a weakened joint environment so that it can stabilize itself and function properly again? I think there could be a lot to go with that. And I think, again, rehab is going to be key for all of this as well. We can't just blanket treat horses without making sure that they're getting the work to perform at the level that they need to perform. And I think there are some horses where all they need is rehab and I shouldn't say rehab, but strengthening and fitness guidelines. And then you'll have a completely different horse when you look at them again. So I am beginning to wonder, what if our polyacrylamides are doing that for our joint environment?
Well, and I think that's really interesting because, you go back to, say, the human back. And, of course, if you're doing a controlled study on that, always one of the groups is physical therapy only. And those groups always do well.
Yeah, absolutely.
And so, surgery, you do that, you back them off the physical therapy because they hurt too much to come back from it. And then you back that. Same thing with our horses. Are we doing that?
Yeah.
I think that's fascinating.
And then I am going to just bring it back a little bit to that orthobiologic side, right? Because we can't get painful horses fit, right? I mean, that we run into that too, and it's in people as well. And backs are a classic one for that. And so the idea where you had mentioned you have a large volume of PRP and you're going to hit multiple articular process joints, I think that can be part of that protocol, right? You hit them, but I'm much more comfortable to do multiple sites and get them more comfortable so then I can get them stronger. And then you may not need to treat them again. Our goal should be to try and treat these with products that we can use frequently, comfortably, so that we don't get them to the end-stage OA where steroids might be the only option we have. Does that make sense?
Yeah.
And so I think if we could reach for orthobiologics sooner to try and support the low-level arthritis and get our horses stronger and working well, then hopefully we're not managing the end-stage OA where it might be a lot to ask some of our orthobiologics to overcome.
And the other advantage that we haven't mentioned, but remains a pillar on which we use the orthobiologics, are horses that are metabolic or insulin dysfunction, or just they're a risk for us to give them corticosteroids. And all of us who've done this long enough have that one case where, God, I wish I hadn't given that horse corticosteroids.
Absolutely. Yeah, absolutely.
And those, that's where orthobiologics shine. They shine in a variety of different spots, and they do it with a variety of different products. But I think, and it's interesting to me that they are more accepted in equine veterinary medicine than they are in human medicine, small animal medicine. I mean, they are already an accepted tool to where you can't really say that about any of these other species we're talking about. So, I don't know, we're doing something right.
Yeah, absolutely. Absolutely.
Well, Katie, thank you so much for kind of helping us with this deep dive into orthobiologics, and we'll look forward to seeing that paper you mentioned about polyacrylamide gel in 26. So,
I appreciate it.
Thank you.
You bet. Have a great day. Enjoy AEP.